Well, I'm almost speechless after that panel. That was just truly amazing and astonishing. I feel like I got baptized a little bit. And so I really, really enjoyed that. So up next, we have a fireside chat, how to foster public health innovation without racism. And joining us is Dr. Zeke Mckinney, the Chief Medical Editor of Minnesota Medicine, as well as Dr. Charles Senteio, MLK Scholar at MIT. And we have Freddie, who will be joining us as moderator.
So thank you, Angel, for those introductions. Zeke and Charles, welcome. Maybe we'll sort of open up with some initial thoughts that you might have on the topic, and then we'll start fielding some Q&A from the audience. Zeke, if you'd like to start.
Yeah, thank you. Thanks for having me, and thanks to everyone who's put this together. I might mimic some of the comments that were said in the last session, but I'll do my best. First, I think it's important just to think about the context of public health. I mean, I would say for everything we're talking about, context really matters. Public health is really about promoting and protecting the health of the populace more than providing individualized care. So I'm a physician who works in clinical occupational medicine. And so, thinking about public health is really more dealing with all the issues even outside of what we see in the clinic. So some of the big barriers, I see in our healthcare system to engaging in public health are, primarily the mistrust and distrust in our Black, Indigenous, persons of color communities, so most of which is pretty appropriate from a lot of issues that have happened in healthcare and healthcare research over time. And so however we can start to address that, whether it's through education or a variety of other means, I think that's going to be really helpful, especially combating mixed public health and political messaging that people are getting nowadays. And so, I think now we've seen with, presidential debates, they're having like real-time fact checking. I think a little bit of stuff like that can be helpful right at the point of when people are receiving information. As they talked about last time, social determinants of health are one of the biggest things. I think you ask any physician, they'll tell you what we deal with in the clinic is fine. I can treat somebody's high blood pressure, but at the end of the day, all the stuff that's happening outside of clinic is a much bigger driver of an individual's health. And so that's, I think, where, public health solutions are going to be most needed and most relevant. Of course, there's also underrepresentation, both in healthcare research and public health. I mean, I'm Black, and 5% of physicians in the United States are Black, and certainly we have way more than 5% of our populace is Black. In medicine specifically, and we see this in public health too, nowadays there's this issue of race-based medicine where, basically either one, we've done studies on or in populations of color that have had, problems, big problems. The Tuskegee syphilis experiment is probably the most historically famous one. We have the inverse problem where people collect a lot of data in non-BIPOC communities and ultimately end up drawing the wrong conclusions. We see that with kidney function and lung function right now. Some of this leads to sort of positive feedback systems when we're like doing risk assessment. So then the people who are already getting the most care end up continuing to get the most care. And sometimes finding the roots of these problems are really hard. So solutions may not be actually targeted at the right place and may end up actually making problems worse. And so I would say most importantly, and this is where, folks with expertise in, computer science, analytics, informatics can be the best, is how do we really measure the outcomes? How do we measure that we're moving progress in this? So hopefully that wasn't too much to start with, but that's what I'm thinking about talking about today. Thank you for having me.
Charles, you want to say a few?
Sure. Thanks for your comments, Dr. McKinney. I'm gonna probably extend some of them and attempt to color in some of that as well, because there's a lot of overlap, as you pointed out. Thanks also to the organizers who put this together and who are putting together the hackathon. I think it's a wonderful event, certainly timely and contemporary in terms of the issues that all of us are facing. And thanks to the attendees who are taking time out of their weekends as well to collaborate over an issue that is so very important. Just to echo a bit about what Dr. McKinney pointed out, as an informaticist, so as a health informaticist, specifically a community health informaticist, I think about access and use of information. And you really cannot be an equity researcher, as I am, in the context of health informatics and not address or think about and figure out how to better measure mistrust. Mistrust is a really tricky construct. And as I've gotten more into putting COVID into my established equity work, I've been thinking a lot about the difference between what I hear from my own network of people of color who aren't researchers, who aren't clinicians, who have absolutely no intention of getting a vaccine, and why, and what I read in the literature about mistrust. So I'll talk a little bit, try to address that, and of course address questions about that, about how mistrust is a very tricky construct to measure as it pertains to health behavior, as it pertains to outcomes. So those pathways are quite tricky, and they were before COVID. So the level of mistrust and how to measure it, huge issue. Again, as Dr. Mckinney pointed out, historical underrepresentation in clinical trials for people of color is now, I hope, more of an issue as we think about vaccines and who and how effective it can be and who we need to participate in that important research to ensure that vaccines are both safe and effective. I gave a talk on Monday about specifically mistrust as it relates to COVID vaccinations, future COVID vaccinations, I should say. And some of the literature that I'm trying to get a little bit smarter on pointed out that no matter the effectiveness of the vaccine, at least 50% of a population needs to be vaccinated. And that struck me as a huge non-bench research issue, because no matter what wonderful work that's being done and will continue to be done by our bench researchers in developing a safe vaccine, and this isn't my line here, but it's vaccinations which keep us safe, not vaccines. So if the vaccines don't end up in people's body, especially when we think about maybe a dual vaccine, so a dual dose, if it's got to be refrigerated, I mean, just think about the logistics involved in getting it, quote unquote, to people. And then add on top of that reluctance and the voluntary opting out of participating in it. I just see a huge public health potential issue. And what we can all do about that might be to just educate ourselves a little bit more on people's individual context for how they make health decisions, how they make decisions whether to seek care or not, how they seek care, what happens when they seek care. So as a informaticist that focuses on equity, I have conversations with people quite a bit, especially now, on how does medical research happen and the inherent ambiguity and arguing that happens there. We researchers argue a lot about what truth is, about how we came about that truth in terms of our methods. Now, those arguments are almost front page daily updates, breaking news. Here's a vaccine, here's this, here's that. And I think that it's important for all of us to understand these contemporary issues. When I used to get updates from PubMed in terms of late breaking research. Now I get it from Wolf Blitzer. And no shade on Wolf, I'm just using him as a proxy. So as these medical discoveries become more front page news, and we are lifting the veil of what we researchers have known since we've been in research, which is that medical discoveries are a lot like democracies. They're messy, slow, prone to arguments. And medical research and research in general is the same way. We argue all the time about what truth is. In the context of COVID, in the context of escalating mistrust, that ambiguity and uncertainty is, I think, a huge public health issue that all of us have a role in our conversations, in our participation in events like this, in our writing, in our social media presence, have a role in trying to articulate, yes, we're not sure, but we're also not sure yet. So the notion of uncertainty doesn't mean incompetence. It actually means competence. It means we're trying to get sure. And that process is messy. And I have done my best to try to learn about that and articulate it in a way that makes sense to people who aren't clinicians, who aren't researchers, and who are carrying with them, as we all are, a legacy of structural racism with a foundation of white male supremacy.
Well, thanks for those initial comments. Maybe to start taking maybe one slight step backwards, which is, as part of this hackathon, the hope is to really provide a venue for innovation, for new ideas to come, for new solutions to get developed. Maybe can you at least briefly touch on what exactly innovation in public health means? Does that mean a startup venture that provides some new ways to do data analytics? Is it more of a awareness campaign or educational initiative? Is it more on the policy side of things? And kind of provide the participants with at least some context of what does innovation in public health mean?
Well, I guess I'll field this first. And first of all, thank you, Dr. Senteio, for your awesome comments. I mean, I think talking about, COVID-19 vaccination and how this engagement and research is really important to our communities of color is a contemporary issue. I'm actually a co-investigator on the AstraZeneca site trial here in Minnesota, the only one in Minnesota. And one of the reasons to do that was to try to, reassure our communities that, hey, this is a way you can help, and this is a way you may want to get involved, and here's what all that means. And so going full circle to what Dr. Senteio was saying, I mean, education is really at the heart of this, and I think that's where we can probably do the most innovation. So we heard about over the past couple of decades, some informatics solutions like, personal health records as a way to sort of, I'll carry my medical records around with me on the phone, and now I don't have to worry about each electronic health record system talking to each other. Interoperability, is not a realized dream as much as we would like it to be at this point. But I think it's even less so in the context of public health. So, I don't know the level of expertise of everybody on the call, but, there are these things within state public health departments called immunization information surveillance systems, IISs. And so those are public health information systems where they collect vaccination data. And this isn't consistent nationally, and not all of them also are interoperable. But if you sort of extrapolate this thought of a personal health record to sort of your own personal public health record, what are the areas of social determinants of health that, that may affect you? What kind of area do you live in, and what kind of issues in terms of environmental pollution exist for you? What access to food do you have, in terms of distance to get there and transportation? What is your education level? Maybe we can give people a quiz and say, what do you expect when you go to the doctor? Or what do you expect in terms of when you're supposed to get vaccinations? And that way, you could have an app that sort of fed back to them all these things. Or, oops, I just moved from Minnesota to Florida, and shoot, now they don't know what I'm vaccinated against. But I have it here on my public health personal record. I can just bring it with me and pass it to the public health department there, or they can all sync them some way like that. So I think having, more tools in the hands of the individual consumer, patient, whatever you want to call them, and allowing them to control more of that narrative, and also personalizing it based on, whether it's their level of education and their level of resources, access to healthcare, access to insurance, access as far as even some of the barriers that Dr. Senteio was talking about, and even being able to measure those for individuals is a huge thing, because that might tell you how your apps or your solutions need to interact with the individual. I bet Dr. Senteio has a lot to say about everything I just said.
I love it. Yeah, I mean, I think the on the one hand, the potential that we hold in these computers that we carry around and cameras, thank goodness, that we carry around is huge. And using and tapping into these larger sort of population-based databases are wonderful. I want to also mention that in the health informatics arena, especially in our sort of research community, some of us who are interested in equity also recognize that simply putting, say, a patient portal, accessing a patient portal via a phone, as we all know, is a very different experience than on a computer. And we have what's called intervention-generated inequalities, or IGI. What are IGIs? IGIs are actual inequalities or inequities that are exacerbated based on an intervention that requires use of a technology which either is not accessible or as accessible or accessed in the same way as the designers intended. So I use patient portals for a specific reason. In part of my work, I've worked with low-income older adults, for example, who have smartphones. It's not the issue of whether they have a smartphone with an appropriate data plan. It's what they use that phone for. And for many people, the notion of accessing their personal medical records on a smartphone is socially and culturally a disconnect, that's not what they use their phones for. And those of us who design systems, either at the sort of hospital-based level, community-based level, we need to understand that there's wide variation among populations, even if we use something as rough as payer status as a proxy. Within that, we might have broad social cultural differences in terms of how people access technology and what they think about in terms of where to get health information and where our trusted resources come from. Because just because you have a cell phone and a data plan doesn't necessarily mean that culturally you're going to think about accessing your patient portal. And I haven't even addressed the issues with dexterity, with vision that are required to make sense out of what's on one of these screens. And I know for me personally, every time I say to myself, boy, I want to get my computer out to look at this thing, I try to make sure I catch myself and say, what about my parents? What about older adults who, even though they might culturally embrace the notion of getting health information on their phone, but because of physical dexterity or vision issues, it's rendered inaccessible. And that's where intervention-generated inequalities may come from. So those of us who are involved in developing technology, designing technology, need to think about inequity, and I'm including myself in that, so that we're not actually exacerbating existing inequities using technology or designing technologies that either culturally are just out of reach or just technically are out of reach because of things like visual ability and dexterity.
So follow up on that. One aspect has been, this is one comment that you made earlier, Dr. Mckinney, is, in terms of the metrics for some of this work and how it develops. Obviously, I think in population health, that tends to be on a much longer time scale than people might really know. And so what could be some potential sort of surrogate markers that people can use to essentially as ways for continuing to iterate on the development of whatever solutions or new innovation that they're bringing about that would continue them on the right pathway towards the ultimate outcome?
I'll jump in here, if that's all right. Okay, so ultimately outcomes, we know what they are, right? We've got morbidity, right? We've got mortality. We've got life expectancy. We have childhood indicators in terms of infant mortality. So we have these public health measures that ultimately measure the health of populations that have been around for decades. I try not to deviate too far away from them. And as you mentioned, Freddie, the pathways are so important. If we can start with what we call in strategy consulting, begin with the end in mind. What ultimately are we here for in terms of those of us who are focused on equity? We're focused on equitable outcomes. Ultimately, life expectancy, and I know that there are some nuances there in terms of life expectancy doesn't always mean quality of life, but for the sake of this discussion, let's just land on that. Infant mortality. I learned early in my health research experience that there are those are kind of the two ultimate markers to define sort of the health of a population. Life expectancy and infant mortality. There are others, but what I want to emphasize is that let's start with those ultimate outcomes, because in the health equity world, and I'm sure in other realms of research, we tend to make certain excuses for populations. And we say, well, for this population, we see escalating numbers. Therefore, we won't necessarily hold those same markers, hold those teams and those groups accountable. I've oscillated a bit on that, but I'm firmly in the camp of ultimately, if we want equity, we have to bring these numbers in alignment for people of color, for LGBTQ, for especially native populations. We see it all around us. So ultimately, I look at the majority marker and I say, that's the outcome we need to get to, and let's build those pathways to it. And let's do our research so that we can define some pathways. For example, as I opened with, medical mistrust to health outcomes, because that's not a direct line and it's quite complicated. And I think that we, as researchers and public health professionals, should try to refine those critical pathways so we can understand more about how social determinants influence ultimately what we're headed for, which is, I hope, equity according to life expectancy and infant mortality.
Yeah, I'm going to go ahead and have to agree with Dr. Senteio that our ultimate outcomes are definitely those in public health, and we should never lose sight of that. I think more a little bit to Mr. Nguyen's point, which is, how do we do that in the short term? Because, mortality is not a needle we're going to move every day. And so I'm going to sort of integrate a little bit of what Dr. Senteio said is, let's find the pathway to, changing mortality numbers. So let's say you make an app or some type of intervention to do this. Yeah, you might not see mortality change for 1, 2, 5 years, but, just to what Dr. Senteio's point is, look at from before, look at how users are using your app. Oh, gee, well, it looks like people above 55 are not really engaging in this. Why is that? Well, I don't think we see very commonly that people are doing, user experience design where, there's different interfaces for different populations. We're just now seeing, your big social media ones adding like a dark mode. Okay, great. Welcome to year 2000. But I think there could be different ways to interface with these tools because, yeah, for my parents, looking at a small screen is hard. My mom has, problems with her hands and, touching on the phone all the time in that way, or certainly on a keyboard, is really, really hard for her. So designing those interfaces is one way, and when you can see more shorter term metrics like engagement and use of your application as one way to do that. Okay, well, what was it designed to do after that? Maybe we wanted to get people to go into the doctor more. Well, are we seeing that needle move too, whether it's in claims data or in electronic health data? Okay, now are we seeing greater medication compliance? And so your pathway, I think, from looking at an innovation all the way to our standard public health measures of morbidity and mortality can have a lot of steps along the way. And I think thinking about those really critically and sort of designing that sort of analytics pathway to get there will make it a lot easier to sort of measure what success looks like. And so then when you get to your end of your 5-year period and it's like, well, gee, we expected a greater jump, greater improvement in mortality. Why didn't we get that? You might have some ideas of where, some of those barriers were. But again, thinking of all the different populations and how they will interact with these tools socially, culturally, in terms of barriers, physical, intellectual, whatever, are going to be a lot of layers to how to get into that.
One of the questions that came up during yesterday's sessions was that more state and health departments and local health departments are labeling racism as a public health crisis. How does that change the landscape, whether that's in terms of those pathways to innovate or the resources now available to address these issues that participants might try to leverage as they start building out these solutions?
Well, I think it really gives voice to what sort of the primary root cause is. Even though there's about 1 million downstream effects from it, but it's going to allow us to get more funding from legislatures. It's going to allow us to have a real platform to stand on when we're, speaking in venues like this, rather than, people saying, no, I'm not racist. It's like, look, we already know this exists and it's implicit and explicit, and you don't need to deny it and you don't need to be offended about it. It's true for me. It's true for you. It's fine. Now let's just get past that and move to, okay, how do we address all the things that come downstream from that, all of those social determinants of health that are impacted by systemic racism? I don't want to take too much time because we're getting to the end here.
Pick up a couple of the... Oh, go ahead, Dr. Senteio.
I was just going to say, I think it's important to put that name on it because there was not so long ago, and I'm sure still in pockets, where there was a pretty ardent, strident opposition to that, that the very notion that there's racism involved in clinical consultations, like that's just an amazing thing. I know I've had to use, of course, data to substantiate when you look at some of these differences, these inequities in terms of, for example, the access to pain medication in ERs across the country. These are not veiled or even sort of singular in their in what they tell us. So I think putting that name on it is super important, just to lay it down and say, we know this occurs. Now let's figure out what we can do about it.
So I'll take one question from the Q&A here. Someone's asking, has anyone defined the requirements to get to healthcare equity? But this might be a good question, but without helping people meet these requirements, there might be all for naught. And this could be a very long, drawn out process and constantly changing, but what is the baseline that needs to be formed, or has it been formed yet?
So going back to what Dr. Senteio said is, I mean, our baseline marker is going to be morbidity, mortality, and when those are equal, we're good to go. So here in Minnesota, we actually have greater inequities than most places, and it's not because people of color are doing worse. It's actually because, you know, our quality of healthcare and our quality of education here are above average, and so that gap is even bigger. And so what do we do to narrow that gap, to bring everybody else up to that place? That's your line in the sand. It's pretty easy to identify that. Of course, it's very hard to get there, and it's a circuitous route.
Maybe one last question, which is, within public health, what are the low-hanging fruits that you feel can really be addressed through a hackathon? What are these areas, especially for doctors? For example, many underserved communities delay or don't get care because of cost. Do you feel that you can find patients, quality, procedures taking into now the cost factor as part of establishing equity?
I'm not sure who was that to, Freddie.
Whoever would like to answer.
Go ahead.
Well, cost is a issue. It's a barrier. I don't want to make it seem like it's the barrier, though. There are social, there are cultural issues that prevent people from accessing care, even when they get a card in their wallet, which is important. But early on in my experience in healthcare, actually early on in the Affordable Care Act debate, which may actually be happening again soon, unfortunately, about the merit of a more universal coverage. Yes, coverage is important, but it's necessary but not sufficient. There are several other factors that provide or that are present barriers to accessing care. Among them, what we've been talking about. If I have insurance, if I have good insurance, but I think that I'm treated unfairly in terms of the system or the healthcare institution that I go to, or the providers that I see, or the people that check me in when it's time for me to have an appointment, then that's going to naturally, I think that these things are not so distal for us. If we think about them on a more human level, some of the comments today have been about, don't forget about the people behind some of these numbers. And it's easy for all of us sometimes to forget that, but try to get connected to what other factors might influence you from accessing care, given that financial barriers might not play as much of a factor, given that we're on this particular event. I'll just go back and I'll end it here. I'll go back to one of the wonderful quotes that I heard early on in my sort of medical training, or a clinical training, I should say, and research training, by Dr. William Osler, which is ask not what disease the patient has, but what patient the disease has. If we stay close to individuals and knowing that behind these awful numbers, which sometimes can even get difficult for those of us who look at them frequently to fathom, 200,000 people dead and counting, like what does that even mean? But behind that, there are real people. Probably some of us have been affected directly in our networks, and our families represent those 200,000 people. So what I try to do, and what I implore us to try to do, is to stay close, that there are people, there are real people, human beings that are being affected directly and indirectly by these awful, inequitable numbers.
And I want to respond to this question too, and not to even combat what Dr. Senteio said, because I agree 100%. It has to be very much person-centered above all else. But if we want to look at it on the flip side, which is what's the system-centered way to sort of drive what's happening from the care side, right now medicine's trying to, in theory, move towards what they call value-based care, which is why these outcomes matter. And it's even an outcome as simple as, what are the interactions that, you know, your clerks or your clinic assistants or your administrative assistants at the front desk are having with your patients. And so I think because healthcare has been so much cost driven, I mean, I think that was the heart of this question. we have to start putting a marker behind that. You know, there was an article in Health Affairs blog earlier this month, and I had even posted something like this on Twitter too. You know, what if we started putting value-based care markers on health equity in terms of, gee, if you know your health disparities get narrower, we're going to reimburse you better, and if they get wider, we're going to reimburse you worse. Sure, that may not be the perfect solution, but I'm just saying, you know, starting to look at it from that perspective might give us a way to start moving this needle a little bit better, because right now healthcare is very much business driven and they're looking quarter to quarter. They're not worried about morbidity and mortality 2 years down the road, but we need to be able to help them understand that. And so being able to show a return on investment of these things, which I think is not as hard as it would sound, really will then start to move that needle and push us more into that value-based care space.
Thank you so much, Dr. McKinney and Dr. Senteio, for this lively discussion. We'll end this current session here. Thank you again for your time this afternoon.
Thanks for having us.
Thank you. And it's really not a fun panel unless we argue, right, Zeke? So next time.
I think we were congruous.